Our webinar this morning. We have joining us Dr. Mona Morstein from Arizona, who is going to be covering naturopathic approaches to diabetes. And I am Dr. Joanne Yanams. I'm the Executive Director for the Association of Accredited Naturopathic Medical Colleges, hosting you all today. And so with that, before we get started and before I introduce our speaker, Dr. Morstein, if you can just go to the housekeeping slide, that would be lovely. All attendees are, that's okay.
Sorry.
All attendees are in listen-only mode, and we will have a question and answer session, so there will be time for you to ask questions. We ask please use the Q&A box in Zoom, though, not the chat, just so that we can track our questions a bit better. The forum is recorded, and we will share the link. If you are having any issues or difficulties, please email us at info@AANMC.org, or if you have anything else that comes up through the course of the day. And so with that, I will introduce our speaker. Dr. Morstein has been a practicing naturopathic physician for over 31 years. I'm super excited to have her with us today. She is very well recognized as an expert on diabetes and as the author of an in-depth, evidence-based book for patients and physicians titled Master Your Diabetes, a comprehensive integrative approach to both type 1 and type 2 diabetes. Dr. Morstein is the founder and executive director of the Low Carb Diabetes Association, the owner of Arizona Integrative Medical Solutions, former faculty at the Southwest College of Naturopathic Medicine, and a graduate of NUNM. She is the past recipient of the American Association of Naturopathic Physicians President's Award for her contributions to the profession. And so with that, I will turn this over to Dr. Morstein. You are all in very, very capable hands to learn about diabetes today. And so thank you, Dr. Morstein.
Thank you, Dr. Yanez. Thank you. All right, so moving forward, I guess that's what just was gone over very well with my bio. I mean, just one other aspect of me is that a whole nother part of my, it's good. I mean, obviously I see a lot of diabetes. I see all hormonal conditions in men and women, and also gastrointestinal conditions. And I just love working in both of those fields. I mean, I'll see anything, but that's a big part of my practice. And what I love working about it is these are just ways that naturopathic physicians can have such success in helping people really heal. Here's my book. You can get it on Amazon. It's written both for the person with diabetes, caretakers, and physicians. So it really is readable for any person who's interested in diabetes. So for myself, I got involved in diabetes early on in my practice. After I graduated, when I went, it was NCNM. I guess that was college. Now it's NUNM. And I did my residency there, and then I moved to Montana. And I learned about Dr. Richard Bernstein from a colleague of mine in Montana who actually had type 1 diabetes, had discovered Dr. Bernstein's book himself, Dr. Bernstein's Diabetes Solution, had worked in his practice with Dr. Bernstein, and mentioned it at a quarterly meeting of our Naturopathic Association in Montana. And so I was the second naturopathic physician to go to Dr. Bernstein's clinic, which is actually out of his house and above New York City, and worked with him and learned a lot, and then came back and continued to really learn about diabetes, not just from the conventional side, which is, of course, medications, insulin, non-insulin injectables, and so forth, but merging it with naturopathic medicine and many ideas that are in the literature, but Dr. Bernstein, being an MD and being a conventional doc, really wasn't aware of or didn't follow. So when I started getting pretty good at it over the years, and I started teaching diabetes, and I teach physicians how to use, how to treat people with diabetes. I've done insulin intensive webinars, because if you're going to see diabetes patients, you do really need to know how to use insulin. And at this point in my career, obviously, which is quite far along, but I do see type 1, type 2, kids, adults, all patients with diabetes, and work with them very well and enjoy it. Can I get that poll? I'd like that. Can we please have that poll taken off the page?
You can just
Oh, okay.
click on it and it goes away.
Oh, okay, thanks.
Yeah.
So, okay, so can we, okay. So, so diabetes is pretty rampant in this country. Right now, there's 34 million. So essentially 1 out of every 10 people just in our country has diabetes. And another 88 million have prediabetes. So this now, if we add that up, literally 1 out of every 3 Americans is either pre-diabetic or diabetic, and 1 out of every 4 seniors over 65 has diabetes, right? Which is 14.3 million seniors, or 20, about a little more than 25% of them. So this is a really rampant problem in America and costs billions and billions and billions of dollars each year to our country. Now, there's more types, but the basic types are type 2, which is the predominant type, which is generally associated with abdominal adiposity, weight here in the gut. And it's noted by insulin resistance, where people make insulin, but their body cells don't react to it anymore. Now, insulin lands, so you have a cell and you have a receptor, and insulin lands on it, and that sends a chemical into the cell that says, go out and grab glucose and pull it into the cell and either burn it as energy, or insulin mostly directs that it's stored as fat. When people are overweight or even obese, cells have enough fat in them. And they basically say, forget it. No, we're not taking in the glucose. We're not turning it to more fat. We got enough fat. And that's insulin resistance, that insulin is being made, but the cells are just not going to respond to it anymore. There's no chemical signal anymore. They're like, forget it, no way. And so this is when we start then seeing the blood sugar getting higher, because it can't enter the cells. And when it reaches a certain number, which is 126, fasting, a person is diagnosed with diabetes. Now, type 1 diabetes is an autoimmune disease where the person's own immune system, their own white blood cells, attack and destroy the cells in the pancreas, which we call beta cells, that make insulin. So these people just don't have insulin anymore to secrete, and they have to be put on insulin. Latent autoimmune diabetes of the adult is a type 1, which usually type 1 classically occurs from ages 1.5 to 25. And so if a person gets it 35 or 40 or 45 or 50, if they get type 1 later in life, we actually call it this LADA thing. There are other forms of genetic type diabetes and so forth, but these are by far the most common ways we see diabetes. And it's very likely that all of you in the audience know somebody who has diabetes, because it is so common in our country. And of course, part of that is because 70% of Americans are either overweight or obese, and that tends to be weight that's gained, here in the tummy. And that is the kind of fat that makes us the most insulin resistant. So what we're going to talk about is how NDs manage type 2 diabetes, the labs, imaging, prescribing, and, a little bit, and then I'll go over a case. So the way I set up my practice is my first intake is an hour and a half, which is much longer than anybody gets in a conventional care paradigm. And that intake is, I'm doing a big intake on their history, their diabetes, many aspects about it. Do they have any complications? Do they exercise? What kind of glucose meter? How often do they take their glucose? What are their health history? What's their medications, etc.? Things that also might have gone in their past that might lead them to develop diabetes. For example, environmental toxins and things that they may have been exposed to could have caused or helped cause their diabetes. I do all of this intake, and then I do a physical exam. And then I'm going to likely send them away for some labs and see what is going on with them. I send them all home with what is a diet diary for a week. So I have a form where they're going to write down everything they eat and drink, breakfast snack, lunch snack, supper snack, any symptoms they have, their bowel movements, brand names, etc., and a glucose graph where, depending on the kind of diabetic they are and the kind of medication they are, I have them check their blood sugar at certain times of day so I can see where their blood sugars are. Say we're just talking about a type 2 diabetic patient who's not on insulin, then I would do fasting and then an hour and a half after breakfast, lunch, and supper. And then they come back for the second visit. That's another hour. It's an hour and a half if they are on insulin, but let's say they're not on insulin. So we set up then the whole protocol. I have I don't know, is it 8 or 10 page handout that I walk them through what they can and cannot eat as a person with diabetes. We go over exercise, stress management. We go over supplements. We discuss their medications. Everything is put together in a very, very organized fashion in that second visit. And then we have follow-up visits, generally monthly, just to check in and see how things are doing. We set up when we're going to renew labs and so forth. So though I break down all patients into this first gather data, second organized treatment. And it really works fantastically well. These are typical labs that I do with patients. The CMP, it means glucose, liver, kidney, electrolytes. CBC is your red and white blood cells, lipids. Serum ferritin is the first sign that a person has fatty liver if it's significant, if it's elevated. So if it's elevated, then I'll do an ultrasound and we'll see just, how fatty is their liver. Because when you have a little bit too much weight on you, it's going to store all over the body in the liver. And fatty liver is actually fairly dangerous. It can, over years, start elevating liver enzymes and go into fibrosis and cirrhosis, just like an alcoholic can. Although a person isn't an alcoholic, it's just too much fat can cause significant inflammation over the year. So it's good for us to know so we can help protect the liver. Also, that is a good positive encouragement to lose weight, because if we lose weight, we lose the fat. You can see the other vitamin D3, HSCRP is inflammation. A1C tells us where your blood sugar levels have been over the past 3 months. I check the thyroid, and then anything else that's specific to a patient that they might need. So we're going to do whatever is pertinent. Then the treatment, as I said, diet, exercise, sleep. Now, sleep is important. If a person is overweight or obese and they say they snore, I'm going to make them do an obstructive sleep apnea test. Because if a person has sleep apnea, that is going to cause them to gain more weight, have more sugar cravings, increase their risk of blood pressure and cardiovascular disease. It's really working against them. So we have to make sure a person doesn't have sleep apnea and that they are getting good sleep, for 7 to 8 hours a night. We have to deal with stress. If people feel they are stressed or anxious, that can raise their blood sugar. We look at detoxification. I'll talk about that a little bit more. And then supplementation and medication. So all of these are gone over to be a comprehensive care. Now, what about the diet? So this is a busy slide. There's two main diets. Well, that's not true. There is one main diet, and then there's this diet, which is an outlier diet. So this diet, which has been shown in studies to be very effective, is a high carb plant-based diet. And there are studies showing that a high carb, low fat, plant-based diet can really benefit people with diabetes. And you can see that these were done on type 2 diabetic men with very poorly controlled, with very high A1Cs of 8.5. That's a very bad score. And they ate very high carb diets with like almost no fat in it. And here was a typical diet that they were fed, right? And so eating this way did everything we want to see happen. Lowered their glucose, their A1C, their lipids, cholesterol. They lost fat. They gained, without losing muscle. And they all got off insulin. So this is pretty awesome and pretty amazing. And there is a group of people, actually, ironically, the mastering your diabetes people. I master your diet. They're mastering. And their whole diet recommendation is kind of eating this way. But for most people, this is the best way to go. And 99.9% of my patients do a low carb diet. And a low carb diet is clearly evidence-based as the best diets for people with diabetes, both with type 2 diabetes and type 1 diabetes. So this article came out written by 26 physicians and researchers, including, you can see, Dr. Richard Bernstein, who I worked with, on showing that carbohydrate restriction is the first kind of best approach in diabetes management. And this is incontrovertible evidence on how effective this is for patients. And this is what, it reduces blood sugars. Literally, you can lose 100 points of blood sugar in a week going on a low carb diet. And of course, they can really stop the need for medication, help people get off of medication, no side effects, anything like that. Now, this study in pediatrics wasn't really a study. It was actually a questionnaire sent out to a group called Type 1 Grit, which is a Facebook forum advocating low carb. And so what they learned is that these people use low carb diets to treat pediatrics. And I don't know. So I think my arrows are supposed to be a little lower. So exceptional glycemic control of type 1 diabetes with low rates of adverse effects were shown to be in patients who had type 1 diabetes and did a low carb diet. So this is by far the diet that I work with my patients and is so successful. The other thing about this diet versus the MAPI is that this diet can be used socially. You can go out to eat, you can eat with other people. I mean, if you're in the MAPI, it's so limiting socially because nobody else eats that way. It's like a macrobiotic diet, and you're not going to get this eating at other people's homes or eating out. So this diet also makes socialization so much easier. And low carb, now, exercise. So we talk about cardiovascular, which is either, and as well as, so resistance is supposed to be its own bullet, not an in bullet. So so cardiovascular is one bullet. This is, of course, walking and hiking and an elliptical machine and treadmill, where you get up, and just are moving steadily, raising your raising your pulse. Resistance should be its own bullet. Move it to the left. Resistance is weights, kettlebells, bands. It's kind of isolating one muscle group and using it specifically at that time. Resistance burns more glucose than cardiovascular does, and it builds muscles. And muscles are really the biggest cells that burn glucose. So if you're doing muscular work, and then even when you're watching TV, you'll be burning more glucose than someone at the same weight with less muscle. So if people just have 15 or 20 minutes to work out a day for some reason, doing the resistance is definitely a better way to go for burning glucose and building muscle. The HIIT, the high intensity intermittent training, is when you kind of you're walking for 3 minutes, then you run as fast as you can for 30 seconds, then you walk for 3 minutes, then you run as fast as you can for 30 seconds. It's this kind of, working at a regular rate, and then the intense rate for a shorter amount of time, and doing that for 4 or 6 rounds. And so people can get just as good cardiovascular and good muscle gain, taking less time to do in this HIIT. But people don't really like that. It's more intense. And honestly, a lot of people would just assume do the treadmill and then do some kettlebells versus putting together this really intense HIIT. So however they're doing it is fine, but this is a very valid way to exercise. Weight loss exercise is an hour a day, 5 days a week. So we don't get weight loss just doing 20 minutes on a treadmill a day. And for most of our type 2 diabetics with need weight loss, we've got to get that exercise bumped up and find them, make them find the time in their day to get this done. Now, the other thing is, people can do 45 minutes of cardio at one set, or studies show you can eat and walk 15 minutes after each meal and get the same equivalent exercise. So if 45 minutes is a little too much for someone, to walk 15 minutes 3 times a day is also going to suffice. For sleep, as I said, we do have to check for sleep apnea. If a person has sleep apnea, they have to get corrected, whether it's a CPAP or BiPAP or a medical orifice, dental orifice, a dental guard. These are really how we have to treat it. We have to make sure, as I said, they get sleep. That means sleep hygiene. That means turning off lights in the house by 8 o'clock, except maybe a couple of lamps. Getting off the computer or your cell phone at least an hour before bed so we don't get that blue light interfering with sleep. Keeping the bedroom dark. And so they say cool, but I don't like cool. I like warmer. I'm a chilly person. So however your bedroom needs to be to sleep better. And then also understanding that the waking up, blood sugars are the highest in the morning waking, and that's normal because many things happen biochemically and hormonally during sleep to cause our blood sugar to be highest in the morning. So that's not weird or anything. It's typical. And until people get that weight off, the morning glucose can be the most difficult one to get normal versus once we're up, into the morning and afternoon and evening, we can get good blood sugars then. But that's normal. So we just have to explain that to people so they're not concerned. So cortisol does increase glucose levels. And cortisol is a stress hormone put out by our adrenals. Now, stress is a subjective analysis of a situation in life. And there may be 3 people in the same situation, and 2 may think, I don't care. And 1, it may freak them out. So it's an attitude about a situation that you're living in. And so learning to change that attitude is a huge part of all of our lives, right? And helping to mitigate those feelings of stress and the effects that it has on our body is very helpful. Now, this also may mean sometimes people, are in a bad relationship, or they have to change their job, or they may be in a situation that is so unhealthy or imbalanced. And I don't know what just happened there. So now you're seeing my email. I did not touch anything. So
No, we're still seeing the presentation.
oh, okay. So, okay, that's weird. I don't know how that, okay, so so you can't see my email. That's weird. Okay. So stress management. So there may be times that, patients are in some really an abusive relationship, or, a workplace where they're required to work 80 hours a week, or, just that may not be tenable for controlling cortisol levels and helping them better regulate their glucose. But say it's not in anything extreme along those lines, then we do need to work on how can people manage stress better, whether it's a gratitude journal, prayer, friendship, creativity, writing, painting, getting into nature is always a good thing to do. Learning to say no and realizing it's okay to say no. Doing things like yoga, tai chi, breathing exercises, meditation. Not everybody's going to resonate with all of these methods. So my job is to work with the patient, help them find ways that they do resonate and that they can incorporate into their life. And it may just be 5 minutes of meditation or a breathing exercise in the morning and at lunch and supper, something, or at bedtime, something super easy, or it may be something else that they want to do. And whatever it is, we just need to support them and work with them to make it something that they're doing regularly. The gut microbiome. So the gut microbiome has a lot to do with what blood sugar is like. And so, for example, if short chain fatty acids are made from fiber on a low carb diet, we're really getting a lot of fiber out. They can't have beans, they can't have grains. So we need to make sure that they're getting in fiber as a supplement to keep their short chain fatty acids happy, because short chain fatty acids help regulate glucose in the body. So these are all the things that can be related to better or worse glucose control coming from the gut, whether they have good or bad bacteria, whether they have low bile acids. So believe it or not, having low bile acids can reduce your ability to regulate your glucose levels. So we've got to talk about all of these things and look at them and see if a person has had a lot of antibiotics or comes to me with diabetes and gut upset. I may want to check their gut health and fix that if it is also imbalanced, because that may have a significant effect on how they can regulate their blood sugars better. So there was this new study that giving fecal microbiotic transplants really stopped the progression of type 1 diabetes in patients who had just been diagnosed with it, which is pretty amazing. So we have a lot to go in terms of science. Whoopsie.
Dr. Morstein, I'm not sure if your slide is stuck, but I think we're still on the stress management one.
I'm moving it on my computer. I don't know what happened.
I think you might have it open in a different application. So
I didn't
it has
touch anything.
Okay.
I don't know what to do. I mean, let me just, hold on. Let me just, can you
Yes.
see that?
Uh-huh.
All right, well, let's go try that again. I honestly, is that better? Can you see the slides now?
Yes, we can.
And this
Thank
is
you.
the gut microbiome?
Yep.
Okay, I don't know. I wasn't there. Okay.
It's okay.
So this is the slide on the gut microbiome that I was just talking about. So we do need to make sure people get extra fiber in on a low carb diet. Detoxification, both chemicals heavy metals, and mold mycotoxins are scientifically associated with causing insulin resistance, beta cell damage, autoimmunity, etc. Even the World Health Organization says that arsenic and lead can cause type 2 diabetes. These POPs, which stand for persistent organic pollutants, are shown for sure to cause type 2 diabetes and maybe even lead to type 1. So healthandenvironment.org is amazing if you're looking into chemicals and all different kind of ways that toxins in the environment can lead to diabetes. That's the website that you want. And they have a weekly newsletter. So we may have to do some detoxification in people as well. I'm not. These are the medications for people with diabetes. We like metformin. That's a great drug. Really doesn't cause any complications, except maybe it upsets the gut in some patients. The problem with the other oral meds is that, they're really problematic. Sulfonylureas can burn out the pancreas, so make people need insulin earlier, and they also have the highest risk of low blood sugars. Nobody uses glynides, which are kind of baby sulfonylureas. A glyninide, you have to take it every meal. Sulfonylurea, you just have to take once a day. So obviously, patients just want it once a day. DTP4 inhibitors, honestly, don't do anything. They lower the A1C maybe 0.5, and a low carb diet can lower it 4. It's crazy. It's not a very effective drug. The other drug I say is okay. The TZDs, nobody prescribes anymore. They were associated with a really horrific study with a very bad outcome, and no doctor wants to prescribe them anymore. And then we have glucagon-like peptide 1 injections, which are great. They're awesome. So if I have to use medications with people with diabetes, type 2, I start with metformin, and then I want to leap right away into the GLP-1 injections, which reduce appetite, help with weight loss. You can inject once a week. Everybody's okay with that. And then insulins, which obviously we don't really want to do at all in type 2 diabetes, but sometimes if patients have been very poorly controlled for a very long time, that damage to their pancreas can require them to need to be on insulin, even though they're a type 2 diabetic. And then here are the supplements I use. I always give everybody good multiple vitamin mineral. I always give everybody fish oils. I give a diabetes product, related product. I have made one, so I'll recommend the product I use. I will give everybody fiber recommendations. Most people should be on some extra vitamin D. And then that's the core. If they need something else based on other aspects of their health, okay, that's fine, but that's very unique to each patient. But every patient will get this protocol. And what's nice about the diabetes product is that it contains, like one product contains like 10 different things at a really good therapeutic level. So there's a lot less bottles doing a lot better, a lot greater good. So in complications, I can't discuss that here. Read my book. The best way of dealing with complications is to not have them happen, but we can reverse many complications, stabilize them. The first key is to get the blood sugar really good, which is an A1C of 6 or less. If you have high blood sugars, you can never correctly deal with the complications, right? So the first thing with all complications is getting that blood sugar down, because that's what causes the complications. This is a quick case study. This is a 58-year-old pilot, and he develops type 2 diabetes. He has an A1C of 8.2. He's not allowed to fly if it's above 7. So he's at risk of losing his job, his income, supporting his family, everything, his whole career, if he doesn't get this diabetes under control. And he's been dealing with it with an endocrinologist, but it's still not under good control. So I did my first visit where we did the intake and labs, a dietary glucose graph, set up the whole protocol, talked about the low carb diet, his supplementation. He was already on metformin from his MD, and we just kept him on that. We got him learning to exercise better. And we also, a big part of his protocol was that he flies overnight. And so he flies overnight. Dang it. Sorry. Okay. I had a timer going. So he flies overnight to different countries, and he's got to figure out, how do I eat low carb flying these long flights and at hotels? How do I get my exercise at hotels and so forth? So it was a lot of travel discussion of figuring things out. And sometimes this is things like YouTube videos, which you can just do in your hotel room. There's a bazillion exercises free on YouTube. Like I do my kettlebell workouts to free YouTube videos. There's all different kind of exercise videos free that you can do in a hotel room, and so it's just kind of brainstorming that. And so so we put him on the supplements. In 1 month, he's got back to exercising. He hadn't done it for years. He really likes it. He's feeling better energy. He's starting to see his weight shifting, and he's figured out, eating, traveling, and he's already lost 8 pounds in the first month, right? On the low carb diet and just basically starting things. Well, after 3 months, his A1C down to 6. So that they allowed him these 3 months to the next A1C. If his A1C hadn't been down, he was going to lose his job. But now it's down to 6. So he's good for the year now to keep his flying. He loves the protocol. He's got the traveling all figured out now. He's very confident. He feels like he's got control of his life back. He's lost another 12 pounds. And so it's just, this is simple stuff that really makes a difference when you put it all together. So last, what I love about naturopathic medicine, you help people heal. You help people get better. We're doing it naturally. We're making people excited about taking ownership of their health. We're making people excited and empowering them that they're not a victim of this or that they can get control, they can be healthy, they can just, live their lives in a way that make them healthy and keep them healthy. And of course, it's my job, so I earn a living. I pay my mortgage. I have some savings, and I'm pretty happy about that. All right, I think I'm a minute over time.
No, you're fine. Thank you. Thank you so much, Dr. Morstein. Before we go to Q&A, would you mind going to the next slide just so I can tell folks about the upcoming?
Sorry, didn't know. Okay, there you go. Sorry.
That's fine. So we have upcoming events. We are going to be covering colds and flus on December 3rd. We also have our virtual fair on December 1st if you are a prospective student and you're thinking about this as a career. And so, Dr. Morstein, you can probably put your contact info back so that folks can see how to get you.
Was there
there we go. And so with that, we have a few questions that have been coming in. There was one question, if you could just go back to the diet plan again, that had gone through pretty quickly.
I didn't take time to write out everything that encompasses a low carb diet, right?
Sure.
Did they want to go back to the MAPI diet?
Yeah, I think that was the one, possibly. There we go. Yeah, that was pretty quick. And then there was a question about SCFAs and short-chain fatty acids affecting glucose levels. Can you just cover that in a little more detail?
Yeah, so in our gut, we have beneficial bacteria, generally in the family called Firmicutes. So Firmicutes are bacteria. When we eat fiber, they break the fiber down, they ferment it into short-chain fatty acids. Now, short chain fatty acids are the food for the colon cells. And having low short chain fatty acids can increase your risk of developing colon cancer and so forth. So, but short chain fatty acids not just feed the colon, they actually can be absorbed into the body. They're very good for brain health. Butyrate is associated with helping people with Parkinson's disease, autism, many good things. And in the cells, they also help reduce insulin resistance and help regulate blood sugars and also fat metabolism. So this is one of the big reasons that getting a lot of fiber in your diet is so important, and why when we're taking out some really huge sources of fiber on a low carb diet, we have to make sure we're adding fiber powders back in to support the microbiome and short chain fatty acid production.
Thank you so much.
Not that you can't get fiber in vegetables, avocados. I mean, you can get fiber in, but we're just making sure there's even a bread, like there's a great bread called, the number one bread I recommend to low carb patients now is Base Culture, because it's a low carb bread, Base Culture keto bread, or there's 7 nuts and seeds. And each slice of bread is only 4 grams of carbs, but it's also 4 grams of fiber. That's awesome. So if someone has like a sandwich at lunch, they just ate 8 grams of fiber. That's huge. So there's a lot of ways that I talk to patients and give them recommendations for foods that have fiber, as well as saying a little bit of fiber powder wouldn't hurt either.
Excellent. In your years of working with diabetic patients, what would you say has been some of the more challenging things that you're faced?
I mean, the number one challenge is getting people to exercise. Like many people don't have a habit of exercise. They don't want to exercise. They're making their lives too busy for them to feel they can exercise. They start exercising, then this happens and they stop. Honestly, getting people to embrace exercise and make it a regular, steady part of their life is probably the diet they'll do, the supplements they'll do. They love getting good sleep. They'll do the CPAP. They'll do other things. But exercise is the most difficult. We have a huge population in our country of people who have never embraced it. And it's a big thing for them to start doing regularly and incorporate.
Thank you. And along those lines, when you're seeing students, because I know you've been faculty at schools and so on, what is the most important thing you think students should know or practitioners should know when working with the diabetic population?
I mean, the number one thing is insulin. And there are huge blocks, with practitioners wanting to learn insulin. Obviously, yes, you can kill a patient with insulin, but it's when you're matching insulin to low carb diets, it's so steady and easy, but insulin is complicated. It's difficult. There's lots of different insulins. You have to figure out how to use it. Are they using injections? Are they using pumps? You have to regulate their basals. You have to figure out, how do we deal with insulin with meals and exercise? And what happens if they get sick and fever or diarrhea? And so insulin is the big barrier for a lot of docs. They don't know insulin. It's not taught at medical schools. They don't want it. It's very scary for people and complicated. Patients don't want to go on insulin, and so that's the most difficult thing in terms of education with students, even current physicians. But if you really want to be a physician who's an expert in diabetes, I think it's incredibly irresponsible to not really understand insulin, because many patients are on it.
Thank you. There is a question about Mediterranean diet. Obviously, there's a lot of buzz on that with metabolic syndrome and heart disease. But can you speak to that with diabetes?
Yeah, I mean, so if people are pre-diabetic, there was a very good study showing that the Mediterranean diet, like with some exercise, was a lot more protective against people getting diabetes than metformin. Is significantly more effective. So now the omnivore diet is really just a very healthy omnivore diet, right? No junk food and no pop and no candy bars and nothing along the lines that people just tend to eat, fast foods, etc. But it is in the literature very well established as a very effective diet for pre-diabetes patients. I wouldn't do it for patients with diabetes. It does have a lot of grains in it and things that just aren't going to work for a low carb diet. But pre-diabetes with exercise, it's very well understood to be an excellent diet plan.
Thank you. And when you're working, there was a question that came in about anti-inflammatory foods. So there's also, there are so many diets out there. There's the left eye diet, the right eye
Yeah.
diet, and so on.
I loathe the anti-inflammatory diet that's found on the internet is a diet that I loathe. It's so restrictive. Like, it's so easy for a physician to sit at a desk and say, don't eat any of these things, right? Including like nuts and seeds. Like, really? Show me one study that says macadamia nuts causes inflammation. Like, this is made up stuff by people, and it somehow it just catches ground like on the internet. So, and nobody needs to not eat. Like, if let's say we're not a diabetic, if we're not diabetes, like beans are not pro-inflammatory, nuts are not pro-inflammatory, eggs are not pro-inflammatory. Like, these they're just not. Now if you have a certain food sensitivity, that can be, so we want to remove individual foods that individuals react to. But to put huge groups of people in these made up, super restricted diets, removing super healthy foods, like I'm not anti-grain. Now you have diabetes, okay, we've got to do things differently. But like, grains are awesome for people. I don't think people should necessarily not eat grains. Oh, they're anti-inflammatory. Really? Again, show me a study that says brown rice, or millet, or oatmeal. So for the general person, anti-inflammatory, no junk food, no fast food, no refined sugar, no soda pop, no, these are no overeating. Eat breakfast, lunch, supper, don't snack, fast from supper to breakfast. These are just simple things that are significantly anti-inflammatory in a person's body, as well as avoiding whatever food sensitivity that individual has. I do food sensitivity testing all the time, drawing blood, sending it to a lab, measuring 184 foods. And if someone is sensitive, temporarily they don't even, you pull out all the foods, patient comes back in a month and their psoriasis is cleared up, and then you add all the foods back in one at a time to find the one food that's really the problem, and the rest can be added back in. So I want people to eat as much variety in as many groups of food as possible. That's how people are happier, that's how guts are happier, and that's just how I work with patients.
Thank you. So there, I think as you mentioned, the time restriction, intermittent fasting is getting a lot of play in the media right now, and that's something that also just came in.
Yeah, I mean, intermittent fasting. So here's the deal. The point of intermittent fasting is just to eat less food. oh, I'm going to intermittent fast, for 16 hours and I just eat 2 meals. Well, okay, you're just eating 2 meals. So to lose weight, well, that's eating 2 meals. I mean, that's great. But the idea with it, the only way intermittent fasting works is if you're eating less calories. They just did a study where they did intermittent fasting, but the two groups, ate the same calories. There was no real caloric reduction, and it didn't show it did anything at all. So the idea is, you intermittent fast, but you have to eat less food. Now, I think everybody should intermittent fast. Everybody from supper to breakfast at 12 hours, just because you don't need, we shouldn't snack late at night, before bed, anything like that. So you eat supper at 6, and you don't eat again until say 6 in the morning. I just think that's healthy for every human being on the planet, every adult human being on the planet. You want to do 14 hours, okay. I personally don't, I don't make my patients go 16 or 18. I mean, there are people that eat one meal, every 24 hours. Like, how do you enjoy life that way? Like, and I'm not very happy when I'm hungry personally. I get a little hangry, so we want people to enjoy life. The other thing I dislike nowadays is this idea about food. Like, food is bad. Food has to be controlled. Food has to be disciplined. Like, whereas food is this amazing blessing, if you'll allow me to say, that God has put on this planet to nurture us. I'm in Judaism, we believe we eat food to get energy to go do good things, to go help people, to go make a better world. And food is a blessing. It's social, it's spiritual. And the attitude toward food, like over these last years, has been something to dominate and control, and it's bad and it's evil and this is bad and this, and it's a bad attitude to food, and it's a bad attitude to eating. And so I try to get people like this, that pilot, he didn't do intermittent fasting for 16 hours a day. He did do from dinner to breakfast, but he eats 3 meals a day. I eat 3 meals a day. And so these are ways that, I mean, there's always the what's out there, but we don't have to buy into everything out there. And for some people, it can be very effective, but it's not a general rule that I make everybody follow, 14, 16 hours, stuff like that. And I really strive to make them understand what a blessing food is.
Thank you. There was a question, just a distinction between dietary changes for diabetics versus pre-diabetics. I know you're a big proponent of, eating whole foods and watching carbohydrates if you are having trouble regulating your sugars. But how do you make that distinction with folks that are pre-diabetic, kind of on that teeter?
It really decides. One, we can do labs, right? So pre-diabetes. So when you wake up, your blood sugar should be between 80 and 85. So if you're at 98, and so the non-pre, so, and blood sugar goes to 99. So up to 99, you're kind of normal, but you really should be 80 to 85. 100 to 125, you're pre-diabetic. And 126 and above, you're diabetic, right? So if someone is 101, and their A1, so an A1C, up to an A1C of 5.5, it's considered normal. We kind of like it not above 5.3. From 5.7 to 6.4 is the pre-diabetes level. And then 6.5 and above is diabetes. So if my patient is at 100 and their A1C is 5.7, like, they're just getting their toes in the water of insulin resistance, versus if their blood sugar fasting is 120 and their A1C is 6.4, like in 2 months, they're going to be a diabetic patient. And, we've got to be more aggressive. So a lot of it depends on also what's their body type. Are they already very overweight? Do they exercise? I mean, you're looking at the whole patient. but the labs can really help you figure out, are we kind of mildly insulin resistant, or are we, one step away from having diabetes? And then the diet can be adjusted accordingly.
Thank you. There are a few questions. I know we're starting to come close to time here on sensitivity testing as well.
Food sensitivity testing?
Yeah.
So I do IGG food sensitivity testing. I've done this for my whole career. I find it so accurate and so helpful to understand which food or foods are not working for that patient, that they have a sensitivity to, not allergy. Allergy is IgE antibodies. I'm doing IgG, delayed food sensitivity. And when people come to me with asthma or migraines or eczema or irritable bowel or inflammatory bowel or gallbladder or so many other chronic conditions that I need to see what food is not working for them, I do this test. The test, I use a company I've been using for 17 years. I've actually been to their lab. I'm very confident in them and their quality. And this test, when you get the test back, there may be 20 foods or so that they're sensitive to, but they're really only sensitive to one or two. And because they've been eating this food and didn't know about it, it can harm the leaky gut, harm their gut, make it leaky. And so other foods can sneak in through the leaky gut, but they're not real food sensitivities. So I will pull all of those foods out, give them something to heal the leaky gut. And then when they come back and their GERD is gone or something, say there's an improvement. If it's 100% improvement, I will start adding foods back in. If it's 80%, we'll do like one more month, keeping all the foods out. And then I add foods in one at a time, like they eat it twice a day for 2 days. And if that's a problem food, they'll get their symptoms back. If it's not a problem food, they don't get any symptoms and they can add that back in. It's definitely incorrect to get a food sensitivity test from a physician and you're not allowed to eat any of these foods again for a year. That's not how the test should be dealt with in any way, shape, or form. And then we usually we have these top 10 foods, gluten, dairy, eggs, soy, almonds, tomatoes, corn, these foods that can come up over and over as main food sensitivities. And usually one of those is the problem, and they can add in all the other foods and their gut is healthier, they don't have leaky gut anymore, and so forth. And then they just need to avoid that food and they don't have whatever symptoms or condition they had coming in with, right? So it's a mainstay test I do in my practice.
Thank you so much. So we are right at time, Dr. Morstein, and I just want to personally thank you for joining us today and sharing your 31 plus years of knowledge on this topic, and just very appreciative. I know we've had a lot of folks in the audience thankful for the information as well. And so with that, if you wanted to just put your contact slide up again, in case people wanted to check you out online.
Well, drmorstein.com.
Perfect.
drmorstein.com. We'll get you my website.
Excellent.
Yeah.
Well, thank you so much for joining us, and I hope you have a great rest of your day.
My pleasure. Thank you.